So here is a case of a massive pulmonary embolism, and just to give you an idea, this is a massive pulmonary embolism that we would consider taking to the lab. So one of the questions asked in the earlier webinar was, you know, if you had somebody who was in the ED and cardiogenic shock, you know, 3 pressors, you know, they coded a couple times, would you bring them to the lab? And I would say, if they're, you know, if they could get TPA, I would give them systemic TPA, because that is effective. And yes, you're going to swallow the issue of possible bleed risk, but you're trying to save somebody's life at that point, and I don't know that you would necessarily have that time to spare. So pushing TPA would be appropriate in that. But we do see this kind of a massive PE patient come into the ED who is very sick. They're hypotensive, but they're a stable massive. You know, they're somebody you're going to want to bring right away. And you see this patient, 54-year-old, acute onset chest pain, shortness of breath, tachycardic. So for that, they get their PESI score of 1, even though this is massive, hypotensive, hypoxic, on and on rebreather. And this is images from the patient's CT, and you'll see that there's a saddle pulmonary embolism with obstructive PE in both the right and left pulmonary arteries. A cut lower down, you see this is the RV to LV ratio. It's 2.5. Don't need calipers for this. Clearly, the patient has RV dysfunction. We did our protocol, jugular vein access. That's the PA gram. You see the pulmonary pressure is 59 millimeters of mercury. Again, that's the pigtail catheters. We put our multi-sidal EKOS catheters here from the jugular vein approach. We ran our protocol 1 milligram an hour for 12 hours through each catheter, heparin at 500. And this is what we typically see. So people might be very worried about how much time are you going to give this. I mean, how worried will you be by treating such a patient? And what we have seen is somewhere around, you know, anywhere between 60, most often around 90 minutes to 2 hours, patients will start to stabilize, even with that little of TPA that has already gone in their system. And so this patient at 90 minutes post-infusion, the heart rate dropped, the pressure increased a little, still hypoxic, but now on nasal cannula at 4 liters. The patient found it easier to breathe and speak. And again, that's another reason why we like going jugular, because the patients are a little more comfortable. And the other thing is for these PE patients, we really do not want to intubate them, because intubation and acute PE with this kind of RV dysfunction, they can get very hypotensive very quickly, and so that's something we'd like to avoid. The next morning, this patient, their heart rate was normal, pressure was normal on 2 liters at 99% O2 sat. Because this patient was put in a trial, we did do a CTA at 48 hours post, and that's the cut from the RV to LV ratio. And here's the before and after in this picture. So obviously a very significant change in that parameter. The patient was in the hospital for 3 days and discharged on rivaroxaban. So Xarelto, that is one of our 2 go-to anticoagulants post-PE. We use Eliquis and Xarelto. A lot of that is dependent on insurance and what some insurance companies will pay for and what they won't. So here's another example. This is a submassive pulmonary embolism patient, a 58-year-old male who had a history of prior PE, diagnosed with protein C deficiency, told to be on lifelong anticoagulation, but he's a marathon runner. And he was looking to find an internist who would actually take him off his anticoagulation, and he did. And then he had run a race. He noticed that his times were slow. And he worked for the post office, and he noticed that climbing steps the next week, he was like really winded. So, you know, he got encouraged by his family to come to the ED. He did have a little chest pain, shortness of breath. He knew what it was. He was in a little bit of denial, but he was hemodynamically stable. And this was his cut from his CT, and you could see he definitely had RV dilatation. LV was kind of squished. His RV-LV ratio was 1.8, and you could see here on a coronal reformat from the CT, you could see obstructive thrombus in both the right and the left pulmonary arteries. These were his right heart pressures, and then his pulmonary pressure was 54 millimeters of mercury. And for him, we went femoral. It was one of our earlier cases, and you'll see that we used 6 centimeter infusion length EKOS catheters, and I'm going to talk about that in a second. We did our standard protocol, which was the 1 milligram an hour for 12 hours, and a heparin at 500 units an hour. So one of the things was happening during this case was that one of the catheters kept alarming. And this brought to light something several years ago that we learned, which is the catheter elements, the ultrasound elements are manufactured in groups of 6. So if you have one of these very rare failures of the catheter and you're using a 6-centimeter catheter, you're going to get a catheter that alarms, and then you're not going to get the benefit of having that ultrasound energy. So as I said earlier, we do use mostly 12 and 18 centimeters length for PE. It would be very rare for us to ever consider using a 6, but you need to know that it is very rare but can happen that you can get a failure of the EKOS catheter for whatever reason. It is technology, and that happened in this case. We did switch the catheter out and to another 6-centimeter catheter, not knowing this was the issue at the time, and he had his treatment. And then so right after, his pulmonary pressure went down to 41 millimeters of mercury. Again, he was a trial patient. We had a 48-hour post-CT, and he had significant decrease in his clot burden, and his RV-LV ratio went to 0.9. Here, these are the coronal images from his CT. You can see significant decrease in clot burden. Just mind you, although we see that, that is not a driving endpoint. We do not go for complete clot dissolution. Really, the key for this procedure is reversal of RV dysfunction. That's the one that's the independent predictor for mortality. Clot burden is not. And here is his CT post-lysis, and here's the pre and post side by side. It went from 1.8 to 0.9, which was pretty impressive, and he recovered very nicely. In his follow-up, and we see all of these patients in our follow-up clinic, at 30 days he was converted back to warfarin. He had actually at 30 days signed up and ran a half marathon. At 1 year, he's running without difficulty. He's maintained on anticoagulation, and he's completely asymptomatic. Next, here is a patient, and I think, again, there's a lot of things that we learned, so that was sort of the lesson of that case is really the whole 6-centimeter infusion length issue. Here's a patient, submassive pulmonary embolism, 69-year-old male, presented to the ED with chest pain, shortness of breath, and near syncope. He was normotensive, a bit tachycardic, and mildly hypoxic on room air. So we started on O2. He did have a troponin leak. He had a CTA which showed bilateral PE, and he had an RV-LV ratio of 1.1. So, as I said earlier, this is not severe RV dysfunction. He is symptomatic, but we don't treat all these patients. So the decision made for him, and here just I'll show you real quick. Here's the cuts from his CT. So the clot is pretty impressive. Here's his RV-LV ratio, not very impressive. And so the decision for him was to admit him to the ICU, give him supplemental O2, and watch him. So all these patients who are in this category or worse, we do admit them all to the ICU. But we have a lot of dialogue with our pulmonary critical care colleagues about these patients, and we tell them if at any time the patient starts to require more O2, becomes a little more hypoxic, hypotensive, anything like that, let us know, and we come in. We come in for patients who are going to potentially flip into a massive, and we want to avoid that. So this patient did have a repeat troponin. He definitely had a more significant troponin leak, and all of a sudden he required increased oxygen requirement. They called us. He was now on 100% non-rebreather, and so we called our team in. He was starting to become a little more hypotensive. He was still tachycardic. And so prior to that, they had gotten a bedside echo, and I hope this is playing okay for you on the video. His RV was definitely dilated. You could see there's bowing of the septum here. So he was definitely further dilating his RV. We do not repeat the CTA. That's really not necessary. It's a lot easier to get an echo, and that could give you the information that you need. So we did our protocol. We came in from a jugular vein approach. We placed these 2 EKOS catheters. We ran our infusion in the similar manner that I just told you. About 90 minutes after he started to stabilize. His O2 sat taken from a non-rebreather of 98%. Now he was on 4 liters. I'm sorry, now he was on 4 liters with an O2 sat of 98%. And the next morning he was feeling even better, and you could see he definitely stabilized. We repeated the echo the next day, and you could see from this image that we didn't have that bowing and dilatation of the RV, which was obviously something that was very desirable. So we definitely use echo in these patients, and we do not, unless there's some, certainly not in the acute phase, but we do not routinely repeat the CT angiogram. That's a question I'm frequently asked. Follow-up echo as opposed to CTA. I told you, and again, the key learning point here is it's totally appropriate to admit these patients to the ICU and observe them. We don't treat every submassive pulmonary embolism that comes in. We do observe patients, but any signs of decompensation, we come in to treat the patient. Here is a patient, and I think this is exaggerating some illustrative point I'd like to show. So here's a 67-year-old male presented to the ED, typical symptoms, syncope. He was a little tachycardic, slightly hypotensive, but statting completely normal. He had a BMP elevation, troponin leak, and here this is his CTA. It's not playing, unfortunately. All right, well, here you could see from his CTA, he had a saddle PE, obstructive thrombus in both the right and left pulmonary arteries. And here, this is taken from his lower, you could see significant dilatation of the RV with a really squashed LV. Very, again, don't need calipers to look at this being a significant RV to LV ratio. So, we decide what's our next step. We're going to anticoagulate this patient. These patients all get anticoagulated immediately. And in this case, we decided to do catheter-based therapy. I listed some of the different available therapies depending on your institution. But he was a submassive pulmonary embolism. So we get in there and we measure pressures, and you can see in this case that the pulmonary pressure is 90 millimeters of mercury. So that is very, very significant pulmonary hypertension compared to his systemic blood pressure at that time. But what we did is we decided to place the EKOS catheters, do our protocol, milligram an hour through each catheter, heparin at a low intensity protocol. Now I'll tell you, this was very early on in our experience, and so we brought the patient back down to the lab because our pressures were very elevated, and we switched the catheters out for a Swan-Ganz catheter on one side and a pigtail catheter on the other after 15 hours of lysis. And you could see there really wasn't much change in his pulmonary artery pressures. And even though we did do repeat pulmonary angiography, we really didn't see much benefit or change in his pulmonary thrombus burden. So we were trying to decide what to do. We said, well, let's just continue TPA through his catheters, and we did. And we actually continued that overnight and brought him back down to the lab. And after 30 hours, there was still plenty of clot, and his pulmonary pressure was 100 millimeters of mercury. So we're clearly moving backwards or not making any, or not having any effect here. So we decided let's do a little mechanical thrombectomy. We did that. We had a little angiographic improvement. Pulmonary pressure was about 90, so not really very different. And eventually, he did get a repeat CT. He was now anticoagulated. He had some decrease in his thrombus burden. And ultimately, he did clinically stabilize pretty quickly, actually, and he was discharged on anticoagulation. 2 months later, he came back to the ED with some symptoms, near syncope, palpitations, but he had normal BNP and troponin as opposed to the last time, and he had this CT. Again, for some reason that video is not showing, but his CT showed no pulmonary embolism, but he had some RV dysfunction with an RV-LV ratio of 1.4. We did check with an echo. They didn't think he had RV dysfunction, and he didn't have any pulmonary hypertension reportedly on his echo. So the point here is twofold. One, there are going to be times where you're going to do treatment and you will not get significant change in your pulmonary pressures. And the reason may be, and usually is because the patient may have underlying chronic pulmonary hypertension. And you may not know that going in. Certainly if you see the kind of pressures we did, we probably should have realized that initially, but you're going to have significant elevation of pulmonary pressures in some people because they do have either chronic PE or chronic pulmonary hypertension, and you're not going to get a benefit. But if you've given them the treatment that you feel, and I feel has been established to be pretty safe and effective, you've given them the treatment. And continuing thrombolytic therapy may just now raise your incidence of having bleeding complications. TPA, even though you stop it, even though we do stop it at 12 hours after the procedure, does bind to the clot. And so even though you're going to stop the infusion, you are going to have some benefit of TPA over the next several hours. And so that's why some people will see significant decrease in the pressures when you do follow-up pressure measurements even the next morning. The other reason this case to me is very illustrative is because a lot of these patients come into the hospital, they get assigned the hospitalist, they get assigned the pulmonary critical care, and whoever the endovascular specialist who's doing the procedures. And we see all of these patients in follow-up because sometimes we will have people who had that pulmonary hypertension, and we do make referrals to pulmonary cardiology or the pulmonary hypertension specialist. And then we also, because we are their vascular specialist who was involved in this therapy, we do help make anticoagulation recommendations. We looked at, and we published a couple of years ago, we published 45 consecutive PE, submassive PE patients. And I think the point of this, one point that I want to make is our 30-day readmissions in these patients was 0. And that is certainly not the case in the regular pulmonary embolism population. Pulmonary embolism has a 30-day readmission, according to Medicare data, of about 15%. Now, I'm just showing you in a small sample size, 45 consecutive patients, we had no 30-day readmissions. But if you're around any meetings or any initiatives in hospitals, you know readmissions is a very key thing to be concerned about. And this is something that you might actually talk to your administration about because I think they would like things where they're not seeing readmissions in patients. So, in summary, right before we take questions, I think you've seen that ultrasound-assisted thrombolysis with the EKOS device for PE in acute massive and submassive PE is safe and effective. People have seen pretty reproducible results, seeing decreased pulmonary pressures and RV dysfunction with this EKOS therapy. I think we still do have unanswered questions, and that is hopefully something we're going to find out through some initiatives looking at some randomized trials in the future about which submassive pulmonary embolism patients to treat and what is the best timing for treatment, as well as what is the best dose of TPA and the infusion time. We just completed the Optimize PE trial, which was a dosing trial looking at shorter infusions and smaller doses of TPA to treat submassive pulmonary embolism, and that's going to be presented at the ATS meeting in Washington, D.C. in May. And so I invite you to look forward to those results.